This is a 45-year-old patient with 3 years of symptomatic frequent palpitations, recurrent to beta blocker, with a history of ischemic cardiomyopathy, diagnosed 3 years back with a stent placed in the right coronary artery, and the patient was managed with carvedilol, enalapril, aspirin. This is the ECG of the arrhythmia. Here you can see, well, first in sinus wave, there is a Q wave between of the inferior wall, and extrasystole with morphology of right branch block transitioned to B4, and the axis is superior towards the midline. From B3 to BF, it's negative with RS, and here you can see AT1, which is isodiphasic. The arrhythmia of this patient is 8.5%, and if you want, you can cast your vote. Which do you think is the origin of this arrhythmia? Very well. Well, this is a coronary angiography. Negative myocardial perfusion. This is the echo ejection fraction 37%, and this is the MRI with an ejection fraction of 40%. This is the movement, and as far as I recall, we don't have gadolinium deposit images. Maybe towards the inferior wall. I don't remember exactly. These are the diagnoses: cardiopathy or PVC-induced cardiomyopathy or posterior MPM. I don't see the papillary here. No, I'm sorry. Luis. The papillary is very small as compared to the anterior. ¿Podemos ver el músculo papilar en la resonancia? Estamos buscando el músculo papilar. Well, apparently, the posterior papillary muscle has late enhancement of gadolinium and also enhancement of the lower wall. I don't see it properly here. They are going to help me with some sections, but this is what is described in the MRI. There is late enhancement of the papillary muscle. ¿Lo puede congelar, por favor? Estoy tratando de congelar la imagen. El realce tardío de gadolinio no nos permite ver el papilar posterior. Desafortunadamente, la cicatriz inferior por debajo del músculo papilar posterior, no estoy seguro de si ustedes lo pueden ver. No, yo no creo que estamos viendo aquí el músculo papilar. Teníamos una proyección del eje largo. Can you hear Miguel? Can you hear Miguel? No, but we can clearly see the enhancement. We see the contractility, and if you move on to the next section, you see late subendocardic enhancement, transmural, and subendocardial in the infralateral wall, with extensive involvement of the posterior papillary muscle with enhancement and also a bit of enhancement in the anterior, but we don't see the posterior papillary muscle because it's with entrapment of gadolinium, so it's totally scarred. So definitely there is enhancement in the areas of the ventricle I mentioned and in the posterior papillary muscle. Well, Hector, I didn't hear you properly, but initially it seems that you agree that the papillary in the MRI was on with gadolinium, and there is also gadolinium in the inferior wall below the papillary muscle. So Miguel is going to describe the findings of the intracardiac ultrasound. The eyes. Well, what's important about this procedure is that we did it without fluoroscopy. We introduced first the intracardiac echo catheter guided with images, and there with CRT sound, we got the geometry of the aorta, the aortic arch, and the left ventricle. The first C we saw when taking the images of the left ventricle is the posteromedial papillary muscle. But when I move towards the lateral aspect, it's very echogenic. I don't know whether you can see it now. It's a white line. It's a very echogenic area of the papillary muscle, particularly in the lateral aspect, further up. That echogenic line, I continue to rotate clockwise. The scar begins to thin out. Posterolaterally, I continue to rotate. The wall is very thin, and we see again the anterolateral papillary muscle. Obviously, we can approach this in two ways. You could try to do a substrate mapping to see where are delays and reentry, but the clinical arrhythmia was not ventricular tachycardia, but only extrasystole. So first we tried to map the activation, and then we did pace mapping. The problem we had with pace mapping is that first there were two morphologies of ventricular extrasystole, and secondly, we introduced the ablation catheter and generated ectopy, and there was a similar morphology. With regards to the manipulation of the ablation catheter inside the left ventricle with no fluoroscopy, it should be emphasized that in CARTO, the colors of the tip of the catheter are very important. Let's try to see the left oblique projection. Here you can see the ablation catheter on the intracardiac echo, and you can also see it in the CARTO. The red tip corresponds to the curvature. And when I deflect to the curvature, the catheter displaces towards the red. If I want to go to the other side, to the blue, I have to do a deflection on the opposite direction. So without having to check, you may know where you have to go. Let's now go to the papillary muscle. This is where we ablated. You can raise the left oblique. How do you differentiate if you are in the papillary or on the in the other area? Where this is the visualization of the tip of the ablation catheter. You can see the green pointer intermittently, since it's in the root of the papillary muscle. This is where we find first a lot of high frequency signals. Maybe we can show you the real time. Yes, let's have the polygraph. There, it is very curious. I can show you the histology of Purkinje fibers in the papillary muscle. This is very peculiar. The Purkinje muscle junction is only at the base of the papillary muscle. There is no junction at the apex. So in this area, we find very good maps between 96 to 97% with clinical extrasystole and with very similar activation times between 30 to 35 milliseconds, preferring the QRS. The problem of mapping around the papillary muscle where there are too many Purkinje fibers, the activation times are very similar. It's very difficult to differentiate in 5 millimeters, and that's somewhat frustrating because the activation times are very similar. So in the end, following the pace map, we had 97%, and we applied at the root of the papillary muscle in the lateral margin of the muscle where the scar begins. And now I am moving away in order to avoid ectopy. In the last 12 minutes, we haven't had any extrasystole. The patient continues to present other extrasystole with morphology of left branch block. And that's what we did. I don't know if I forgot something. Miguel, why don't you advance the catheter to the base of the papillary muscle? Well, if I produce ectopy, well, what we show here is the importance of the green tip, of the green dot. Could you please rotate the eyes? Well, here it is. The mapping of intracavitary structures is critical to be able to differentiate whether you are touching them or like in this case, you are touching with that catheter the free wall next to the papillary muscle, because you must assign the activation and the pace mapping points, whether in the papillary muscle or the free wall. That's why the green tip of the software is very important, because it identifies the tip of the catheter. Remember what we have said, when we use intracardiac echography or eyes, what's important is to see the tip of the needle and not the shaft. And the same happens with the catheter. You can see the shaft and you may think that you are in the papillary muscle and you are not. This is the method which we can differentiate where to assign the activation or the pace mapping to the papillary muscle or the free wall. As Miguel was saying, something very important in this case, and any other case of extrasystole, we have to be absolutely sure that the sites of activation are really spontaneous of the patient and not mechanical induction due to excitability, particularly in the bundle close to the base of the papillary muscle. And this is what happened. If you see the morphology, you can show a different point. You can see here the morphology. Give me just the green one. It is very easy and mechanically to induce this type of morphology. Maybe you can see it in the carto. It had a notch, and the rest was very similar. The PASO does not capture this image because the software is based on amplitude rather than on these notches, but the notch makes the difference. When we included the extrasystole that were mechanically induced in the map by accident in early pacing, we are getting some response down here. Therefore, what we did was to filter the extrasystole that we considered as spontaneous, to remove all of those that had notch, and the map oriented us to this area. This is where we have the best base mappings and where we did the ablation effectively. Let me show you how we eliminated the high frequency potential in the second ablation. Yes, in this area with where we are with Miguel, where we have the catheter, this is the early activation zone. We are at the base of the papillary muscle where we can see the Purkinje potentials in this area. And this was eliminated following the initial ablation. I will try to find the electrogram that described that image, but you can see on the screen this type of potentials in sinus wave, in sinus mode. Yes, here is the carto. Yeah, you can see them here early. Do we have the polygraph? Well, can we see on the screen the revision of the polygraph? Luis, which was the dose of dobutamine? Dobutamine. Do you have the chart, the dose of dobutamine? Well, you can see on the polygraph the Purkinje's potential. In the sinus rhythm, you can see the Purkinje's potential after the initiation of the QRS. And then in extrasystole, you can see the Purkinje potential advancing and makes a change in the unipolar potential, as you see in white. This is the area of origin of the extrasystole, which in the end, when we did the ablation, that Purkinje potential was eliminated.
Are there any questions or comments? ¿Es el único ejemplo que tenemos? Vuelve a comenzar, doctor Natale, por favor. No, tenemos tres.
No. Miguel, can they hear me?
Yeah.
Okay. So there was another PVC that had a left bundle branch block morphology. There was a little variance of the, I think Luis explained, with the notching and with more notching and less notching and a little bit wider. The second, after we gave the first application, RF, it came we had a few PVCs back and they were a little bit wider. And that's why we ablated a little bit more towards the other papillary muscle, more on the lateral side of this posterior medial papillary muscle. We haven't had anything after that resembles those. So we are going to give dobutamine to try to induce more PVCs.
Andrea, can you? Yeah.
Okay.
Okay. Que lo van a en la sala 3.
Luis, la dosis de dobutamina, yo le he puesto, hemos empezado a 5, ¿verdad?
Eso es lo que le iba a preguntar a Andrea.
Darle fuerte.
Eso es lo que le iba a Andrea, you hear me? Are you still there? Andrea, we are discussing about the doses for the dobutamine test. So as far as I remember, it's around 40 mics per kilo. Yeah, I have the doses here, but looks very high dose. I think yeah, I have the protocol with me. Just we are discussing with Miguel that seems to be a very high dosage, but we are going to use that just for 10 minutes. So, well, 40 microgramos por kilo por minuto.
So, Andrea, is it give for 40? I don't know. En eco se pone hasta 20. 40, ¿no? No, yo
40.
Yo recuerdo llegar hasta 20. ¿No?
¿Sabes que hubiera sido súper de tomar, Diego, la diferencia del primer mapa totalmente perdido con solo eliminar el notch? ¿Tú lo viste?
The notch. But
sí, pero no tienes cómo volver a marcarlo ya.
Do a remap and take only the notches, the notching. First screen, the very first screen, the initial extrasystoles. This extrasystoles, these PVCs, well, this is a patient, and this is the PVC that when we started. While he connects the computer, frequent monomorphic extrasystoles, OT just defined because it is positive, very basal extrasystoles because it's right branch block with no transition, and much more negative in AVL than in AVR with a biphasic component, which goes from the left axis. That's the case, and Andrea, we're going to present the case very quickly. Good afternoon. I present the case. This is a 72-year-old female patient who comes with a clinical picture of 3 years of duration with non-sustained palpitations with good functional class. She had been worked up previously in this institution, and the diagnosis was focal tachycardia, atrial tachycardia, and frequent ventricular extrasystoles. She was taken to the ablation of that focal tachycardia and ablation of the PVCs. At present, she is managed with metoprolol 50 milligrams. It was discontinued for the procedure, and propafenone, which was also discontinued. But despite the use of these medications, she still had symptoms. This is the latest EKG, where we can see a ventricular extrasystole, which Dr. Garcia was describing. It has a right branch block morphology suggesting a basal origin with an inferior axis, and the right inferior axis, and this suggests then a very basal issue at the lateral level of the left ventricle. This is the extrasystole why she was taken to a procedure in 2016. The morphology is very similar. And I'm going to skip the discussion of the site of origin to continue to comment the case. At present, with an arrhythmic burden of 27% with no sustained ventricular tachycardia as documented. And if you look down here, she doesn't have any more atrial arrhythmia episodes. This is the present echocardiogram. It is within the normal limits with an ejection fraction that is normal for the left ventricle with normal volumes. And these are images of the ablation procedure performed in 2016. Initially, through MAP activation, the origin of this tachycardia was a tricuspid ring, and it was ablated successfully. And when the ventricular extrasystole was going to be mapped, we had some information of earliness in the coronary sinus. We had problems at the time of passing a sheath, and at the time there was hemopericardium, so the procedure was interrupted at that time. In 2016, after that, she was taken to pericardiocentesis with no additional complications for the patient, and at present the diagnosis is a frequent ventricular extrasystole with a 27% arrhythmic burden. The site of origin appears to be an anterolateral structure, basal structure in the left ventricle, and I leave you now with Dr. Garcia.
Go ahead, Andrea.
Can you zoom, Fermin?
Yes.
Can you tell? You use the microcatheter in the CS. Do you do
this
this
is
in
the
every
first I
case?
want to show. Pónganos la fluoroscopia, por favor.
You show the floor.
Yeah, what I want to do, Andrea, it's to show first what I.
Español.
Huh?
Español.
I'm going to speak in Spanish, Andrea. Okay? So, lo que quiero enseñar primero.
What I want to show first is what we consider manipulation of catheter in the venous circulation. It's very important for this purpose to make a very good venography to start with, because the anatomy may be very variable, and maybe the reason for the accident in 2016 has to do with the anatomy of the patient. You can see that it is an anterior interventricular vein and the major cardiac veins that are extremely tortuous. And so this makes it very difficult to advance any catheter. Even the Agilis or any other introducer will make it difficult. So when you understand the anatomy, you can really try to advance catheters, and you're going to try to do it always as you do for any venous and arterial structure under or using the guide wire, so that there is no possibility for the sheath or the catheter to perforate the free wall. Remember, the anterior vein and the major cardiac artery don't have coverage. These are more friable structures. In this patient, what we said was, since there was an early activation in the mapping attempt of the last time, and since the EKG suggests a basal region, we decided to go ahead and place the catheter, in this case a 3 French catheter. We tried to advance the decapolar instead of a decapolar, and it was very difficult to advance the catheter. We managed to advance it to the distal portion. The distal portion, everything there was late, so that's why you see it here between the major cardiac vein and the atrioventricular vein. Please show us the first activation of the coronary sinus, Diego. And here you're going to see that it is very similar to the activation that the activation that was just shown by Carlos. Stop it there, please. You can see it, it's bracketed, and the earlier activation is in the 7/8 lead that perhaps is somewhat early at around 20 milliseconds. So if I were to say it in a way, it's something on the LV ostium superiorly, but very, very basal, of course. And based on these characteristics, we decided that the best thing here was to try not to fight with the coronary sinus, although we try to advance it. Andrea, we try to advance it, but sometimes the coronary sinus may be very, very difficult. Andrea puede mostrar cómo se está acodando el agilis en el ventrículo derecho por la fuerza. ¿Sí lo pueden ver? ¿Sí lo pueden ver cómo se está acodando el agilus? There's so much force, so we are applying so much force to try to advance the sheath given the circumstances of contraction. This is a patient with left ventricular hypertrophy, and the muscle contracts very strongly, and there are very many bends. The contraction force is so strong that it transmits backward, and you can see how the introducer is kinked. And when you are in such a situation and you appear to be early, but you find that you're not going to gain anything in the venous circulation, the best thing, in my opinion, is to go safely in order not to run into complications, and just abandon it and not try to continue to do heroic things here. We made several attempts, so we decided to go out and decided to start mapping from the endocardium. Okay, Andrea, do you have any comments? Fermín, ¿qué camisa están utilizando? Agilis. Queremos ver el eco intracardíaco, porque la parte más importante de este caso son las imágenes del eco intracardíaco que les vamos a mostrar. Live, please. We need it live, real time.
So Diego is gonna handle the catheter. ¿Nos pueden poner la pantalla de eco intracardíaco, por favor?
Can we see the ICE screen, please?
Tiempo real. En grande.
Real time, and we want the large screen.
Okay, counter. Diego, start from the posterior aspect.
Diego, empiece de la cara posterior del ventrículo izquierdo.
Everybody at this point
And
is familiar how to advance this catheter.
Andrea, ya todo el mundo está familiarizado con cómo avanzar este catéter hacia el ventrículo, ¿verdad? So then, this is the septum here. Diego is going to do clock. This is the posteromedial muscle. Continue to go clockwise. And the first thing that we see is a hypertrophic ventricle. It is a thickened ventricle. But look at this area. This is the area of interest to us. The complexity of the group of anterolateral papillary muscles. So give it more clockwise, Diego. And as this comes to the mitral valve, there is an increased complexity of the chorda tendineae in the mitral valve, which has created a lot of problems for moving the catheter. And this is something that you cannot see without eyes. You would try to push the catheter through here, and no. So the problem was to try and get to the ventricular portion of this area. And when you push the catheter, it would go inside all the chorda tendineae, causing a lot of difficulty. For that reason, we decided, like in the previous case, continue to do it, to give it clockwise. You can see how it's hypertrophied with very strong contractions.
Fluoroscopy ahora. Go ahead, Andrea. Did you use a sheet to support you? Yes, I am going to show that.
Sí, voy a que se utilizaron la camisa.
Entonces, obviamente que la
Yeah,
mejor forma
the
para
best way for us to have good contact is to try to use a sheath. And you'll see that the sheath goes all the way down with a dilated aorta, and it helps us maintain the catheter in good contact. This was the fluoroscopy where we ended up doing the successful lesion in this case. So we're going to show the electrograms, or when we did the ablation and the mapping and the maps. Navics and electrograms, please.
la última ablación.
The last ablation and Navics, please.
Precision. Ajá. Entonces, fíjate, Andrea.
Look, Andrea, this area
En el seno coronal
in the coronary sinus helps us guide
era la zona más temprana.
ourselves. It was the earliest area, which is consistent with the earliest area of the previous case. So what we did was to try to guide the catheter based on the eyes and the map to the opposite site, opposite to this area. Can you show when we did the positioning of the catheter, the placement of the catheter?
Y aquí lo que hicimos
And what we did here was to try and look for the best place, but it was very difficult because there were many chordae tendineae. The first lesions were at 35 milliseconds, but then at the end we managed to lower the catheter and place it basal in the area. So I don't know if you can show us 4 screens, the echo and the echo image of the successful location right there, and the electrogram, also the electrogram, please.
pongan la fluoroscopia pequeña y el electrograma.
Fluoroscopy, give us a little screen and a big screen for the electrogram.
Entonces, ponlo en 150.
150, please.
Ok. Y la extrasístole
And the
la pasaste.
extrasystoles.
Al otro lado. Al otro lado. A la derecha. Right there. Okay. So, esta es la localización. Y fíjate,
So this is the location, and in the intracardiac echo, we see the catheter placed very basal, close to the mitral valve, and that was the best site for location, opposite to the earliest activation in the coronary sinus, and this was the electrogram here at around minus 35 milliseconds before QRS, and this area. You can see in the echo the formation of the lesion. You can see it white, how the lesion forms at 30 watts. We didn't go up to 35 because there was a reduction in extrasystoles. And In this place, we eliminated the extrasystoles. We had been waiting for 30 minutes and they haven't come back. And this was the case based on what we activated. And I think that the key is to try to understand the anatomy of the intracavity structures in order to manipulate the catheters around the anatomy in order not to fight with the anatomy and arrive at the place that made most sense, the lateral superior wall without going into the left atrium, because if we go beyond the atrial valve, we're going to be in the left atrium. It's difficult to imagine this if you don't see it in the echo, because under fluoroscopy it would appear that you're very far from the epicardial edge, but there's no more space, and she has a component of ventricular hypertrophy, and therefore we see that large distance from the epicardium to the tip of the catheter. But in echo, we see that there's no place to map because we are right at the contact site. Are there any questions? But so far, this is what we did, and this was the case. Based on the history of the prior ablation with the accident in the coronary sinus and the hemopericardium and the interruption last year, and watching this arrhythmia, why did you want to place the sheath, the Agilis sheath, with that catheter, since there was a danger of going to the coronary sinus, and you didn't? Why didn't you place directly just a catheter from the jugular, or trying to look for the bracketing, advancing it and looking for the same thing without playing with the sheath inside the sinus? It appears to be a good question. I usually I have an aversion to placing catheters in the neck because there is a higher incidence of hematomas and neck problems, which I believe are unnecessary. But I understand what you're saying, and it is true. Going into the coronary sinus from the neck is easier. But what I say is that in this case, we didn't do any extraordinary manipulation. This is very simple. The reason for the previous perforation has nothing to do with entering the coronary sinus. The reason for the previous perforation probably had to do with trying to place the catheter and the tip pushing upward, and they then perforate the venous portion. But if you place a sheath of this type with a guide wire and you do a venography, today I don't see much of a risk of perforation. And this 3 French catheter, which has tip protection, it's going to be very improbable for it to perforate. The axis from the neck to the coronary sinus being more favorable, yes, I fully agree with you, but necessarily a larger catheter might work the same, but it could perforate the same. Now the favorable curve of the neck could be something better also in this case, but since we started with the venography and we recognized the anatomy from the very beginning, we were prepared to not pushing anything. And when we realized the location and the bracketing, we stopped and we went to the endocardium. The neck works. I think it's a matter of practice, and everybody does the best they think. We have had bad experience in the neck with anticoagulation, and our team in general has moved away from the neck, except for very special rare conditions, because the axis from below works well. But I respect your opinion, and I think that it is very valid. And any of the 2 approaches, I think, is functional. I don't think that the previous perforation had much to do with the fact that no, there was an anatomical abnormality, and it will always be there whether you come from the neck or from below. But you need to recognize the abnormality of the anatomy to know where to move or not to move the introducers. We weren't doing anything heroic here in order to go in. It's just a normal thing. You place a sheath, you give it the bend, you give it clockwise, and you go into the coronary sinus. The reason for the kinking was because there was a lot of movement in the proximal portion of the right atrium, and there must be a structure there, and the king of the sheath in the Via Vina Cava. When we recognized that and we thought that we had nothing to do in the coronary sinus, we decided to take it all out in order not to have problems. But I agree with you, when you do something from the neck, you're limited to the diagnosis, and if you want to exchange for an ablation catheter, you're going to have to do it from the neck. And I think that is more radiation for the operator, but obviously you need to protect yourself also. But I agree with you. But we tend to do it through the groin rather than the neck. But I think that it could have been done from above also. And I don't want to be repetitive, but the most important thing is to do a venography at the beginning in order to recognize the type of anatomy with which you're dealing. And having done that, you know how much you can do and how much you shouldn't be doing. I don't know if there are different opinions, but based on that, I agree with you. And I think that it could have been done from the neck, but we did it from the groin.
The distance.
Fermín, ¿cuál es la distancia entre su sitio endocárdico? Parece que es bastante grande, ¿no? Si es una distancia muy grande, por lo menos en el eco entrecardíaco es como de 2 centímetros, pero voy a pedirle a Diego que la mida. En eco intracardíaco, I think it's about 1.5. Probablemente la localización sea intramural, más cerca. Sí, posiblemente hay un poquito de almohadilla grasa alrededor. It's 2 centimeters, 2 centimeters. And what you were saying, that we were going to be better in the endocardium, the pacing of the endocardium was earlier. I believe that if the endocardium pacing would have been later than the coronary sinus, we should have found a way to ablate it closer to the coronary sinus. But here I was reassured because I know that it wasn't the right side. It was, with this 2 centimeter distance, we would have been successful from the endocardium. Usted utilizó, como en el otro caso, salina, solución salina normal, sí. I think that this is important. The only reason why we use half normal saline was because we were in the vein. When we came to the endocardium, we continued using half normal saline in order not to change the bag, because we thought that we were going to cause some lesions and see the effect. In the endocardium, half normal saline doesn't make much difference because we are washing constantly. So the only reason we did it in the last case was because of convenience, in order not to use it for 20 minutes and then change over the bag. But the key reason was because we burned first on the vein. Yes, I have a question, Fermin. Do you think you could have reached this site with transeptal puncture? That's a good question. Excellent question. That was the first thing we did. The next step, we have asked for the needle. I believe that in this area, if we had done transeptal puncture with a curve to place the catheter below and engage it below the mitral, that could have worked very well as well. What happens is that when manipulating the catheter, it was very difficult for us to reach this point. And we got there and we got the pacing or the activation, and then we ablated. But we were ready for the transeptal approach, because you're very right. If we had done a curve, probably we would have better opportunity to come to this side than doing the retrograde. But since we started the retrograde, we tried several times. Unfortunately, we got to the side for early activation. But we already had asked for the transeptal needle. In this area, with this distance, it works better to have a transeptal approach than retrograde, and that was supposed to be our next step. Very good question. ¿Tenemos alguna pregunta o comentario adicional? Bueno, vamos a regresar entonces a la otra sala. Muchísimas gracias, Fermín. Bueno, básicamente en dobutamina tuvimos nuevas CVPs con cambios morfológicos sutiles. Cuando regresaron en 3 o 4 morfologías, una un poquito más consistente que las otras. Tratamos de mapearlo de manera muy similar a lo que habíamos ablactado anteriormente, quizás un poco más apical y lateral. Y ahora hicimos una ablación.
And now we have different variations of PVCs. As I'm looking at this, he's in by Gemini, but they don't really match exactly the PVCs, and they're all very similar in terms of being right bundle branch block, left anterior fascicular block. So what we have decided is we're going to do a substrate map along the scar.
Yeah, that's
And we're going to be
don't you think, wouldn't you expect that, considering that this patient has a big scar in that area?
Yeah, I mean, I was, at the beginning I said, I thought maybe we just find one spot and one focal PVC. It would be nice to just do one ablation and get done, but given this scar and the variation in morphology and the arrhythmogenic potential of being around the Purkinje fibers next to the papillary muscles, I think we have to do a more extensive substrate-based ablation. So we are in the process of getting that map done, and so we got a lot more work to do now. Okay, agarra ahí. Vamos a agarrar puntos, por favor. Me voy al lateral.
Let me go laterally. Yes, in sinus mode, please. And you tell me when you identify the point. Well, the effect we saw with the dobutamine protocol, and we administered 40 micrograms per kilo per minute, which is quite a high dose of dobutamine. Sí, mi fellow me confirmó que eran 40 microgramos. Hasta 50, hasta 50.
40 microgram per kilo per minute, and
Yes.
up to 50.
Yes, I know. I have the protocol. You sent me
which
the
is the protocol that I sent you. Yeah.
exactly. But what I'm saying is that after 3 or 4 minutes of dobutamine at that doses, the patient started to present bigeminism. So definitely there is an effect. That's an important effect, because when we compare with isoproterenol, most of the times looking to induce PVCs, isoproterenol just increase the heart frequency, sometimes producing high inhibition of the PVC manifestation. So looks
Also, Luis, with isoproterenol, you also get hypotension, whereas with the
Absolutely.
you do not. So it's
Absolutely right, Andrea. This is one of the biggest limitations of isoproterenol. Not just that you induce sinus tachycardia and hypotension without a PVC manifestation. Most of the times when we are using isoproterenol, maybe the PVCs come, but after we stop the isoproterenol,
Okay,
so. But in this case was very interesting that after 4 minutes, as I said, the patient started to present bigeminism. We recorded an increment in blood pressure, but it's, not too much. We still continued dobutamine. The effect of the dobutamine is still present, Apparently, even we stopped the dobutamine maybe 7 minutes ago. So looks interesting, to map PVCs. Maybe the problem now is that the patient is in Benjamin's, but the problem is the morphology is changing.
Mira, en ritmo
We don't know if it's an effect of
¿Lo marcaste? Aquí también.
an effect produced by dobutamine, but suggesting that maybe we are dealing with I don't know, maybe some PVCs coming intramurally with different exits and related with the
Well, but you have a large scar, so you expand
Yes.
that. I mean, it's not like a focal. This is somebody that has a substrate that's
Absolutely.
quite large. So yeah.
Absolutely, that explains why different morphologies, but similar between them are appearing. As you can see in the eyes, the scar is, is usual for inferior infarction that starts endo, and then comes below the papillary muscle, the posterior pap, and then becoming more epicardial. You can see in the eyes maybe how a line of echogenicity is below the pap. Do you see that?
Estimula aquí, un momento.
Do you see that? Diego, muéstrala.
We don't see any electrogram now, Luis. Yeah, we see the scar on the voltage, but we don't see any electrogram.
No. I am saying that in the eyes.
Look at.
Sorry. The face
I'm
mapping.
basing in the scar.
You can see.
We can see the scar on the eyes. Yeah, we can see the scar on the eyes.
And this scar is typically starting from the endo,
I have A and B.
Below the papillary muscle, and then coming to becoming epicardial. So it's like.
Es que tenía estimula aquí.
So maybe we have to deal with a scar that has a portion, intramural portion, and actually an epicardial portion. So let's see what happens after we do we can do the voltage map and modulation.
Estimula aquí, por favor. Mira, teníamos un long stem to QRS y el.
Are you doing some pacing,
Yeah.
Miguel?
I'm pacing inside the scar.
Okay, good.
And keep pacing, please. Are we pacing?
Can we see some of the pacing as you are doing it, because that's important.
Podemos poner por favor en la mitad de la pantalla.
Can we put in the middle of the screen the pruca? Pace.
There's long.
Very
let me
nice.
see.
Yes, it's actually very nice. Long stimulus to QRS.
Yeah.
And you also have some, the activation in
Variation.
sinus delay.
Yeah. Okay.
Está
Marca eso.
parpadeando la imagen del polígrafo.
Show the recording in sinus. Look at those potentials.
Marca esos late
They're all
potentials.
delay. Yeah, look at this.
Mueve el mapa hacia la
Clearly,
izquierda, por
that's an
favor.
abnormal substrate.
All right.
Yes.
We're gonna keep going with the map.
Yeah.
It's point by point, so we're gonna take a little while. Hopefully not too long. Okay. Aquí.
Por favor, pueden revisar porque el PRUC.
Can you check why the image is not fixed? Well, we have to choose a sinus point here. Here it's quite large. To the left image, please show me. Move it up a bit more, a bit more. There is a lot of contact. You can choose any point whenever you can. That's a scar, and this has been burned. Well, let's try to identify one point in sinus rhythm. Okay. Okay, let's see the sinus rhythm and try to have better contact.
Actually, there is a good question. Why don't you use a paint array for the map? Because it might give you better definition with the electron. You might do faster.
I am all in favor of that. Yes, that's a great idea.
Actually, that's a very good. Typically, with the consider this is a 3.5 millimeters, so it's a big antenna. So you might miss some
late potential,
some fragmented potential with this color. Whereas with the paint array, besides you can
I'm
do the voltage map faster,
Yes.
you get more better quality recording. So that's
I'm all for it. Let's do it. Yeah.
Ese es buen punto, definitivamente.
Well, definitely pentarray to map anterior infarcts is easier. In this area, we are going to see.
You have a very trabeculated area, you are less likely to cause PVC induced by the mapping. So it's a better way to do the voltage.
Perfect.
Okay, mark that late potential is a really nice late potential here.
Those are very abnormal recording there.
Can you pace, just out of curiosity, here? Pace. All right. No, it's well. There's some delay, but not that dramatic.
Pero la morfología también.
All the morphologies are these are there. He's had PVCs with this morphology. I know we're not always having the same morphology, but
Pero when you were pacing from there, in a moment you reproduce one of the morphologies. So maybe from the same spot you are capturing different pathways inside the scar. So
rotate, lift the image up. Are we getting the pentarray? Levanta la imagen para arriba, hacia arriba, hacia arriba. Gracias.
Yep.
Do we have the pentarray now? Well, I think this is the same, no? Let me rotate a bit. Well, apparently now we are in healthy tissue. Can you choose a point? Well, this looks healthy. I don't know. I'm not sure. This is like lava. What's the amplitude here? 0.4, but it looks like lava. And the wall is very thin. What happened with the pentarray? Well, why don't you ask someone to help you with the map and you help us with the pentarray? Yeah, choose a point in sinus rhythm, please. Please identify a point in sinus wave. This is the apical scar.
Do a pentarray, Miguel?
It's coming.
Yes.
We have it ready? Okay.
Yep.
Well, while we finish choosing the voltage points, can you show us the camera to show the pentarray? We want the Panarex camera. So start washing. The Panarex camera to show the catheter at the feet of the patient. You can focus the tip of the catheter. Is that possible to focus on the tip of the catheter? Come closer to the tip of the catheter, please. Magnify, probably here you are able to see the pentarray. Sí, están con electrodos de 1 milímetro, así que seguramente va a obtener muy buenas imágenes. This is the shape. Sí, porque usted registra de un área más grande al mismo tiempo. Yes, and I think you can see here the distance, the inter-electrode distance, which is smaller, and obviously this allows us to have higher quality maps. In anterior infarcts, if we need to map towards the inferior area, if the papillary muscle allows us to do it and the epicardium, we can collect a lot of information for high density mapping. The catheter needs preparation. It has to be irrigated. So I need to irrigate for the penta. The penta connector. Let's wash. We also use the pentarray often in ablation of atrial fibrillation, and we get better density mapping. However, when you use pentarray, the problem is that the techniques of atrial fibrillation based on the circumferential catheter are no longer feasible. And sometimes to verify the isolation of pulmonary veins with the pentarray can be somewhat difficult. Well, let's do some washing. Now we are washing, and then we will pass the pentarray so that you can see how it works. Okay, irrigation is ready. Well, it's been irrigated. We are going to remove the catheter, the ablation catheter. Give me a saline syringe. We don't want to have any problem here. Has it been irrigated? Yes. We need some help over here for irrigation. Where is the boss? Help us to irrigate the sheath. Activate the penta.
Video and we'll do the closing. Is that okay, or what do you want to do?
Yes, okay.
Is that fine?
Okay.
'Cause I think, unless you guys want to stay.
Yeah.
Yes, you can irrigate the sheath now. Si hay personas en la sala de conferencias y quieren ver el pentarray y quieren ver cómo vamos a terminar el caso, perfecto.
Presented, Andrea?
Yes.
Oh,
Síguelo pasando.
so
Well, accepted Fermin.
yes.
But he talked about the
Yeah,
DLD
this morning we
summit,
talked a
DLD
lot
summit
about
many
DLD
times.
summit.
Yeah.
So we are
We're going with the pentarray again. We're still doing this no fluoro. Show me RAO and LAO. Pentarray is probably still in the sheath. Voy a tratar de turn around this. No. I think.
que lo cierre.
Enséñame.
Maybe
Ahí
to
tengo.
cross the valve, to cross the valve, use a little bit of flow.
I have a loop here,
We are working without fluoro, Andrea.
and let's see.
I know, but
Yes, I know.
A little bit of fluoro doesn't kill anybody.
My back. So I have a too big a loop here.
El pétare está conectado, Diego.
I'm gonna pull it back again. Oh. I'm gonna get back in the sheath and re-advance. What happened to the map? I need to see the map. If I don't have the map, I can't go through. Show me the.
Show the map.
There you go. I need to make sure that I'm through. I don't think I'm through yet.
Yeah, you're still above the valve.
I see. I can see me in the ice. Let me loop it. And now we're gonna advance. And I have too big a loop here. I have too big a loop. There it is. All right. I understand this takes some patience. Let me advance the sheath over the arch.
¿Cómo estamos de ACT? ¿Bien? Perfecto.
Vamos a traerlo y ahora para abajo. Al barrera. Sí, parece que entró, pero no, sigue sin entrar.
Loop it.
Okay. Trying to. I know you're looking at it, and you're saying, why doesn't he fluoro? I have to get some lead.
Oh, you don't have the lead. Okay, that's right. That's a good reason.
I mean, a cusp. All right. A little bit of loop, and then I'm going to go with the entire thing. Está aquí que no.
I am protected.
¿Eh?
I have protection.
Yeah.
Oh.
Okay. We're gonna get this. Just now. I know you're feeling pain. All right. Let's get a lead, and I'll have to cross with. Si me puede traer un plomo, por favor.
Yo tengo, es lo que te estoy diciendo. Ponte detrás mío.
Me pongo.
¿Dónde está el pedal, por favor? Oh.
Yes, sorry. So Luis has the lead. Okay, good.
Can we get a pentarate page?
Por favor, ayúdeme con los equipos acá que quedaron.
Can you show the floor?
Yeah, it's coming. It's coming.
No, Linda, allá. Dani, allá. Rápido, viejo. Dani.
Vale.
¿La flor está bien puesta? No, la flor está muy hacia allá. Actívame la fluoroscopia, porfa.
Vamos a casi.
Activa la fluoroscopia. Ah. ¿Listos? Ya tengo fluoro. Si quieres.
Está todavía ahí. Toma.
You're gonna okay. There. Yeah. So he's trying to make a loop. Yeah, there it is. Okay, that's good. Okay, yeah, advance. That's good. Yes.
Come on.
No, so if you rotate, it will do it. Just, yes. Okay. Okay, there it is.
Crossing.
You're through.
Okay.
Okay, perfect.
All right. Well, He needs to stop moving. Show me.
So let's
Show me
see
left. Show me
can
a
you
left.
see the recording on the Pruka now? From the
Pongamos el Pruka, por favor, el polígrafo.
Aquí ven cómo ven todo el Purkinje system aquí. Agarra puntos aquí, por favor.
So you see much more information, and the quality is significantly better.
Coming back. Okay.
Ah, te sale.
Todo el his ahí.
Ahí está el his.
So those are all.
Andrea, are you using Penta for every case? I mean, VT, SCAR modulation or VT?
Usually VT, SCAR VT we are, yes. Unless we're using stereotaxis, then sometimes we don't, but otherwise we use it for SCAR VT all the time. It just gives you a fast, so look at this recording that you get here.
Are you on the septum now?
Estoy totalmente septal.
Septum or apical now?
Show me a left lateral view.
It does help sometime also in VF storm with normal heart because it gives you less likely to cause PVC and give you a lot of information.
Show me left. Okay, perfecto. Todo
sobre la papilar anterior esta ahora.
Papilar anterior, como vemos, you can see that I'm on top of the anterolateral papillary muscle. It's a healthy papillary muscle. When I got lower, you can see how I'm going to now map the más left lateral, please, en el...
Ponle una lateral izquierda, la derecha. Yes. Voltealo más.
No, exactamente.
Más. Bien. Estamos...
Necesito ver el color del pentary.
The limitation of the pentary here is if you are mapping a scar nearby to the paps, some part of the splines are going to be on the pap and the other on top of the left ventricle.
Aquí lo que decía Andrea de Somi, puedo agarrar muchos puntos a la vez. Aquí todavía estoy en el borde del otro músculo.
Ahí mejor. Mucho mejor.
Let's see if we see late potentials, if those are real or not.
Vamos a ver esos potenciales tardíos.
I'm not sure. This is kind of at the edge of the scar.
Well, you can see that. I mean, those are real.
It's going to be a little painful.
Andrea, in your experience, when you are comparing the voltage map performed by point catheter, ablation catheter, but against or compared from pentary, how is different the scar? Is bigger or smaller?
Look at this, Andrea.
Yeah.
This complex potential we're
That's
getting.
very nice.
That's beautiful. You see how the pentaray is stuck right there in the basal to the anterolateral papillary muscle. Those are not normal, obviously.
Those are very abnormal, yes. Look at this. See how delayed look at the QRS. See how delayed they are. Those are all abnormal.
The question I have, it's for you, Andrea, and for other operators.
Look at this. Even this area. Look at this area, Miguel.
Yeah.
Look at this area.
Well,
This is all.
Yes. Purkinje maybe?
No. This is all delay potential. This is very delayed.
I saw in sinus something.
We have atrial activations.
Next to that.
You can actually see the sequence of delay.
Yes.
Okay, I'm gonna undeflect and get a bit lower. Complete the map a little bit more.
So wait. There is an activation.
Look at it. You can almost track the propagation into the scar from 11 towards,
to 1-2.
Beautiful.
So this is the local. All those are delay, and you have something even more delay. So this is all abnormal.
Okay.
This area is all bad.
So Andrea, the patient presented with PVCs.
Yeah.
Would you support doing an aggressive
I would.
homogenization of this?
Yes.
How? I'm a bit ambivalent about that.
I would, because you have the support of beyond the recording are clearly abnormal, but you have the support of the MRI. So you know that this patient has a large scar. So that's that is a little bit like what we do. Before I mentioned that with structural heart disease we do substrate base, because lead to higher success rate. If you rely on what you induce, you're not necessarily see everything that can lead to arrhythmia. So here you have a large substrate with a normal recording, they are delay. That's something that probably should be dealt with now once you're there.
Andrea, coming back to the question I did before, based on your experience, what about the size of the scar? How is
that's a good question. So there is a difference. The shell with the penta-ray sometimes does not show you all the trabeculation. So sometimes the shell with the penta-ray, unless you are mapping an aneurysm, then it makes no difference. But if you have a trabeculated tissue, the penta-ray might not show you all the sort of the recesses that you can go into with the ablation. But it give you they are abnormal recording that you don't see with the single point, and you see much better with the penta-ray. This is all abnormal. This area is all abnormal.
And looks there is a channel between both scars. Do you see that? Yeah. Red, and in the middle there is like a channel of preserved tissue. Do you see?
Should be at the edge here of the normal and abnormal, and look at those.
So, tag these late potentials, please.
What am I missing? Lift it up a little bit more. Levántalo para arriba, el mapa ese, sí, más para arriba, más para arriba, más para arriba. Gracias. Voy a mapear un poquito esta zona. Un momentito que oriente el catéter. Y me vengo por acá. Todavía no hago contacto ahí.
Está floating. Estás enredado en la cuerda.
Yeah, you got me floating. Está. A ver, que me tengo que venir un poquito más septal entonces.
Ahí pasaste.
Ya lo tenemos, esto ya está
toma voltaje ahí y marca los LED que veas.
Estos cabrones. Ya.
Todos, de hecho, tienen LED.
Aquí más. Agarra estos también. Si todos hay que cargárselos.
Sí. Hay uno, hay uno super late que es el 17. En el canal 17 se ve algo bien tardío.
Pero mira la mesa, sí, curioso. El voltaje, la amplitud no es particularmente baja. That's an important point. This is the concept of the lava, where you have near normal amplitudes as far as the bipolar signal, yet this is clearly an abnormal propagation.
It's abnormal propagation, yes.
Okay. So, marca esos porque aunque no tengan voltaje de cicatriz, siguen siendo anormales. Look at that.
Yep.
Y aquí ya tengo que estar cerca del músculo papilar.
Okay.
Sí, estoy en el borde de... Bueno, en un momento dado vamos a tener que empezar a quemar. Aquí nuevos... Oh, shit, look at that. Enséñame dónde estoy. En el papilar.
We lost you guys.
Last observation, Andrea. When you are using penta-ray, the scars tends to look more patchy, maybe. You know, because the extrapolatio of the information, the resolution is maybe not is higher. So the extrapolation between
well, you have to be careful because here you have some abnormal area with high voltage. So and this you see in non-ischemic cardiomyopathy where the delay potential sometimes have very high voltage. So voltage alone is not an absolute guide. You have to look at the morphology of the electrogram. So here you have some high voltage but very delay that I would consider still abnormal. Okay, so you have to be careful when you define. So it's not just voltage; it's also activation time. So here clearly you have some decent voltage, but they're very delay potential.
Yes, yes.
Show me RAO in the left. I'm trying to get to the lateral aspect. We spent some time under this silly thinking that it would be just focal
Toma.
PVCs, but the area around the posterior middle papillary muscle was never normal. I want to get there. Sígame oblicuo derecha, por favor.
La Rao en la derecha. O en la izquierda. En la izquierda, Rao, perdón.
Agarra aquí puntos, no tiene por qué estar así, allá en ritmo sinusal.
Okay, Luis, Miguel, I think we're gonna kind of, Fermin is here, we're gonna give, show the video and give some closing remark. Then maybe we'll come back and see you in the lab.
Okay.
Okay,
Thank you.
thank you.
Great job.
Thank you. Thank you.
So